A very good evening to everyone, and welcome to our sixth session of the Genomic series. I am Aarti Darra, your host for this webinar, working at Karkinos Healthcare as a bioinformatician. Today we have with us Dr. Jyoti Bajpai Dikshit, a genetic counselor in Karkinos Healthcare, who will be providing valuable insights into how genetic counseling is adaptive and thriving in this genomic era. Before we begin today's session, please join me in extending a warm welcome to Mr. Rajesh Seth, who is in the leadership of Karkinos Healthcare. He would be briefly introducing the Genomic series for us all. Mr. Seth, the stage is now yours.
Thank you, Aarti, and I once again welcome to all the senior doctors, oncologists, researchers, as well as students of this particular branch of medicine, oncology and genomics. So Karkinos is very happy to host this webinar. As Aarti said, this is the series of webinars held. And all these previous webinars, you can find this in YouTube. If you search for this, what is that, Aarti, name?
Genomic series, sir.
Genomic series. So all the previous videos.
Tube on YouTube.
Yeah, so you can watch the previous videos in case you missed any one of them. And as you all know, Karkinos is a focused technology-focused platform, and which provides end-to-end consultation and careful selection of integrated clinical and research workflows using technology with academic rigor. And we also believe in providing excellent cancer care, which is affordable. And this is done by, you can say, four Ds we identified. That is, detect early, then diagnose correctly, and deliver and discover. So today's webinar is a step towards that. That is disseminating the knowledge we have gathered, and particularly our speaker Jyoti Bajpai Dikshit. She is a well-known expert in this particular area, genomics, and she contributes to the day-to-day working of the company, and particularly in genomics, entire field of genomics. So this is the, I want to acknowledge along with him, we have got some other great people like Dr. Moni. I don't know whether he is here, or Rajsekhar sir, or so many other doctors, but their contribution is also equally important. So with this brief background, I would request now Aarti to take over once again, and Jyoti madam to address the gathering.
Thank you, Mr. Seth. That was indeed a great introduction for Genomic series. We are now set to begin today's session, where Dr. Jyoti Bajpai Dikshit will speak on how genomic insights can empower patients. Dr. Dikshit serves as a genetic counselor at Karkinos Healthcare and is a level 2 certified genetic counselor by the Board of Genetic Counselling India. With over 20 years of experience in genetics, genomics, bioinformatics, and system biology, she brings a wealth of knowledge to our discussion. Dr. Dikshit holds a PhD from IIT Bombay and a certificate in Executive General Management from IIM Bangalore. She also has earned an MTech in biotechnology from IIT Lucknow and is a gold medalist in MSc Physics from Lucknow University. Additionally, she has completed a certificate program in digital marketing and marketing analytics from IIM Rohtak. Her multidisciplinary experience spans several prominent organizations, including Strand, Core Diagnostics, Gene Path Diagnostics, and several. Dr. Dikshit's commitment to bridging the gap between laboratory research and clinical application aims to enhance patient treatment and improve quality of life. Please join me in welcoming Dr. Jyoti Bajpai Dikshit. Ma'am, the stage is now yours.
Good evening, and thank you, Rajesh sir and Aarti, for starting today's meeting and giving me a kind of providing a kind of introduction for me. So today, as you can see, the topic what we are going to discuss is that how we can empower patients with genomic insights. So to start with, I will go ahead with the quotation which I had given in my say, you can say the introduction of my webinar also, that Dr. Mary Claire King, who is one of the persons who actually discovered, or you can say who talked about the BRCA mutation in breast cancer patients. She, according to her, genetic counseling is a blend of compassion and science. And why she says so? Because genetics is a complex scientific and technical subject, but useful for common person. And hence, it is important to communicate this information to the common person in very simple terms and in very understandable terms. Hence, that's why it is important that genetic counseling should be done in such a manner that people, common persons, they understand genetics and the use of genetics for them. Now let us go ahead with a couple of more definitions for genetic counseling and genetic counselor before we go ahead exactly into the genetic counseling sessions. So genetic counseling, according to National Society of Genetic Counselors, US, this is basically a process to adapt, or basically for the individuals to understand medical, psychological, and familial implications of genetic profile or genetic contributions to the diseases or to the human diseases. Another definition of genetic counselors from American Board of Genetic Counseling, it says that genetic counselor is a healthcare provider or healthcare professional which has got the training in genetic counseling and basically is qualified to do a couple of tasks like assess the genetic risk, you can say for germline or hereditary diseases for people, also provide education and counseling so that people can understand this complex subject for their use, facilitate informed decision making. Here, it is very important to understand that we help the people in making informed decision making. We do not make decisions for them. Now, second thing is, last but not least, is support patients emotionally. So here, I will let you know in coming slides what all these things mean based on the question and answers which occur during genetic counseling session. Before we go ahead with that information, let us see in which all field genetic counselors work. Genetic counselors work in hospitals, in medical centers, laboratories, research institutions, industries, non-profit organizations, and various other such organizations where genetic testing is taking place or work on genomics is happening. What they do, they help, as I said earlier, in genetic risk assessment, in creating awareness, in psychological support, in providing genetic test information, in making informed decisions, in helping people understanding the results of the genetic test reports. During all this course, what we take care is of the ethical and legal considerations, as well as privacy and confidentiality of results of the patients and the people who are getting counseled. Now, there are various types of genetic counselings, which means in various medical fields like reproductive genetic counseling, cancer genetic counseling, prenatal genetic counseling, carrier screening, rare disorders, and predictive genetic counseling. We will learn about these things in coming slides. And before we go ahead with the counseling sessions, one more time, I would like to let you know that the counselings are of two types, or you can say at two stages when it comes to genetic testing. Genetic testing is something which people want to understand because it is technically and scientifically very, very intense. And therefore, before the test, we do pre-test genetic counseling. And the process for pre-test genetic counseling is that the case is referred, or the patient or the counselee is referred by the clinician or a healthcare provider. Then we make initial contact with them. We schedule the counseling session. In the counseling session, we talk to them about their medical history, their family history of disease, and we also talk about various medical reports and records. And after a rigorous discussion for more than an hour, most of the times, we help them in making informed decision. And after the informed consent is there, the people go ahead with the genetic testing, and this is all done in non-directive manner, which means we help them in understanding everything, and the rest is up to them whether they want to go ahead with the testing or not. Once the test is done, the report is out, and at that moment also, at that stage also, we do genetic counseling for the reason to explain the results of the reports to the counselee as well as their family members as and when required. We also help them in taking the informed actions for future, which might be going and meeting their clinicians, or maybe something else, which is like maybe extended genetic counseling for the family members, depending on the reports of the results. And all these things, as you know, this is something very, very, let's say, you can say very specific for the patient, very, very private for the patient. Hence, the documentation is to be done properly, and as well as the communication has to be very, very, it should be with empathy as well as with accuracy. So it's like compassion and genetics are combined. It's a blend of that. Again, once again, it is a non-directive counseling. Why? Because we do not force to do anything. We just help them, people making informed decision. Now, after all this, where we have understood, or it's a kind of introduction which we have gained about genetic counseling or genetic counselors, now we would like to go ahead with the thing, what we do in genetic counseling sessions. So what I say, genetic counseling session or genetic counseling is basically conversations. Conversations means it starts from queries, inquiries, and curiosities. And then we provide them responses, guidance, and help them in making informed decisions. Now we will go one by one with the type of questions asked during genetic counseling session. So the very first question comes up in common person's mind who is not at all associated with genes and genetics, like what are genes? What are gene alterations or variations or mutations? What is genetic testing? And nowadays, a very common question is, what is NGS or next generation sequencing? So we explain them that I will give a very brief, very short description here. If you are interested, we can have detailed discussion later on. So we tell them that in human body, we have cell, and in cell, we have chromosome. In chromosome, we have DNA, and genes are there in that DNA. And these genes, human body is made up of more than 20,000 genes. And these genes are nothing but the sequence or the code of 4 molecules or 4 letters known as ATGC. And this, let me see if I can use my pointer, but I don't think so. That's okay. So I will just keep telling you which image I am referring to at the moment. So if you see the second figure, I am showing the code for a gene, which is ATGC, the code of 4 letters or 4 molecules. Now, this code has been figured out for a normal human, which means we have a reference human genome, which gives me the code for a healthy human. Now, whenever there is a change or there is a difference in this human reference in a human's genome with respect to this reference genome, we say that there can be chances or there are genetic disorders. If you see the figure here, which is colorful figure, red, green, blue, and yellow, here you can see that at a point where it has to be TA, the pair TA has been converted to GC. So this is known as point mutation. That means change at a point in a gene. Similarly, you can see the next black and white figure. Here we can see that there are large rearrangements. A large chunk of gene has been changed from with respect to the reference gene. So these kind of changes can be cause of genetic disorders. Now, these genetic disorders or these genetic changes are of 2 types. One are somatic changes and the other one is genetic germline changes. You can see here the blue figure and the yellow figure. So here what we are trying to show, somatic DNA changes occur because of environmental reasons, which means, for example, I smoke and I get a change in my genes and I get lung cancer. So these kind of changes are known as acquired mutations or environmental changes. The other type of changes are germline DNA changes, which are present in our every cell, including egg and sperm cells, which means these changes we are carrying since our birth, and we will carry these changes till the time we are alive. And these changes can be inherited. These changes we have got either from our father or from our mother, and we may pass it on to our son or to our daughter. Here, I want to tell you one thing, that each gene has two copies, one from father, one from mother. And genetic alterations do not discriminate between the genders. Except for a couple of diseases, these do not discriminate between the genders. I can get a mutated or a changed gene from my father also and from my mother also. I can pass it on to my son as well as to my daughter. So these changes are there which can cause diseases. Now, how do I know? How to test these? What is genetic testing? That is the next question which generally people ask. So genetic testing means I want to find where the change in the gene is occurring. Earlier, we used to do it single gene, single gene, single gene, and now you can understand 20,000 genes. How can you do all the genes together? But with the advancement of technology, we have latest technology known as next generation sequencing, which allows me to sequence starting from 1 or 2 genes to all 20,000 genes in one sequencing run. Here you can see the process is given here. I will not go into the details of the process, but I just want to let you know that once we get the sequenced gene, we align that sequenced gene with respect to reference genome, and wherever there is a change, we note it down and we talk about the kind of genetic disorder that can happen because of that change. Just let me tell you here that this is a rigorous process. It looks very simple, but a lot of efforts are involved here, starting from sample collection, starting from pre-test genetic counseling to sample collection to DNA extraction to creating the library for the DNA, then running the sequence, then the data is out, which is in gigabytes, terabytes, megabytes, whatever you can say. It's a huge data. It's like finding a needle in the haystack. So bioinformatic pipeline, as you can see, Dr. Aarti, who is actually right now hosting the webinar, she is one of the bioinformaticians, and that is like, say, rigorous data analysis is required, and then we get the variant list, and then we also try to find the most specific variant which is responsible for the disease. So it's like, as I said, finding the needle in the haystack, and then we give the report, which is again explained to the patient through post-test genetic counseling. So this all, we explain it to the patient in very simple terms so that they can understand what is happening with their sample. Now coming to the next slide. Why is genetic testing performed? What is the need of that? What is the application of genetic testing? So if you see the pictures here, I will go for the first for the picture which is given here as I'm showing multiple applications of genetic testing here. So you can see that we can do genetic testing for ancestry, for knowing the ancestry, for paternity, for forensic science, most importantly for personalized medicine and for genetic risk, disease risk. And that is where I am going to come now. What we explain to them, that whenever you are being referred, whenever a person is being referred by a doctor for therapy related genetic testing, what we are trying to find is that personalized medicine for that particular patient. Why? Because earlier in previous days, it was a traditional way of giving medication, one size fits all, one medicine for everyone. Some people are getting benefited, green ones. Some people are showing no effect in between, in the middle, and some people are showing adverse effect, which is in the blue color. But with the help of genomic profile, what we can do, we find the unique genomic profile and associated medication for that genomic profile. So we can find the responders for a drug, non-responders for a drug, responders for a lower dose, responders for a higher dose, or maybe people who are going to show side effects. So personalized medicine is one of the important aspects of genetic testing, and during genetic counseling, we explain this to the patients. Second one, which is known where I'm showing you a family tree. So here what we use genetic testing for germline mutations, and we come to know about the predisposition of any disease, or carrier screening of any disease, or predisposition of say rare diseases or hereditary cancers. We also can do pharmacogenomics using these kind of tests, and whole genome sequencing is one of the tests which is very useful for knowing your say even for healthy persons, for knowing the genomic profile, and based on that, if there is predisposition towards any disease, or if there is if a person is a carrier for certain disease, even if not having disease. And also pharmacogenomics, which helps me in knowing giving the information uh, for a person, depending on their genomic profile, whether a drug which has been developed by a pharma company, whether a drug is going to suit that person or not suit that person, whether a lower dose is required or a higher dose is required, where there are going to be side effects or not side effects. And let me tell you one of my example. I am a cystic fibrosis carrier. So I do not have disease. I will let you know in coming slides why I do not have disease, but I am a cystic fibrosis carrier, and these kind of information we can obtain from whole genome sequencing, even if I am healthy. So we can get this kind of information. How is it going to help me? It is going to help me because I can plan for myself something as well as for my next generation. So let me come to the next slide, which talks about the next question. When I'm talking so much about that, I can pass it on to the next generation. The next questions in my counseling sessions, or in general in all counseling sessions, people ask, what are the chances of passing a gene alteration to the next generation? So there are, if you can see here, we can see various types of inheritance patterns. We have autosomal dominant, autosomal recessive, Y-linked, X-linked, multiple types of say inheritance pattern, including mitochondrial inheritance pattern. What I will talk about only two patterns today, which are most common: autosomal dominant and autosomal recessive. So if I talk about hereditary cancers, so germline cancers, they follow most of the times, mostly autosomal dominant inheritance pattern. What is autosomal dominance inheritance pattern? Let us not go into the details of the technical and scientific terms. Let's understand what I need to understand. It's like, if it is autosomal dominant the inheritance pattern, then I have two copies of genes, one copy from father, one copy from mother, and there will be 50% chances that I may pass it on to the next generation. That is one. Second, even if one copy of a gene is faulty, or even if one copy of the gene is carrying mutation, I am at a higher risk of having that disease in comparison to general population, which means that it does not mean that I'm certainly going to have disease, or I'm certainly going to have hereditary cancer in my example, what I have taken, but I am at a higher. So suppose, let me give you one example, BRCA1 and BRCA2, which are most prominent genes in case of breast, ovarian, pancreatic, and prostate cancer for hereditary cancers. Now here, if even one copy is faulty, then males are at a higher risk of breast, pancreatic, and prostate cancer, whereas females are at higher risk of breast, ovarian, and pancreatic cancer. Again, that does not mean that they are certainly going to have cancer. They are just at a higher risk in comparison to general population. So this is about autosomal dominant. Coming to autosomal recessive. Autosomal recessive inheritance pattern means if one copy of the gene is faulty, then disease will not be there. To manifest the disease, both the copies of gene are to be found. This is the simple way of understanding autosomal recessive, and that is the reason I do not have cystic fibrosis, because cystic fibrosis follows autosomal recessive inheritance pattern. And I have a mutation in my gene CFTR, and that mutation I can pass it on to the next generation, and I have passed it on to my son. Now, my son is also a cystic fibrosis carrier because he has got a gene with a mutation from me, but from my husband, he has got a clean gene. So he is also a carrier. So autosomal recessive disorders do not manifest until unless both the genes are faulty. So we become only the carrier in case of autosomal recessive disorders. And if both the genes are faulty, then the chances of having disease are high in comparison to general population. So this is the way we explained it to the people, that how the mutations can be passed on to the next generation. Then the next question arises, it's okay, you have told me everything. What is the process of genetic testing? So as I told you in the beginning also, during my pre-test counseling and post-test counseling explanation, the test request is given by the doctor, or also for whole genome sequencing and for pharmacogenomics, sometimes people want to know about it. The test request comes in, and then we do pre-test counseling. We tell them everything about the test. We tell them, we take the family history from them. We talk about medical records, and then once they have been informed about everything, if they are ready, then informed consent is taken and the sample is collected. For precision medicine or personalized medicine, I will let you know what are the samples, and I will also let you know what are the samples for germline mutations. So the sample is collected, the sample goes to the lab, the quality of the sample is checked because it is a very high intense scientific and technical process. So the sample has to be good, enough quantity of DNA has to be there. So that is, the quality is checked. Then next generation sequencing experiment is run. The data is out. The data is analysis is done through bioinformatic pipelines, and then the results or the data is again there for interpretation. The data interpretation is done by you can say the biologists and oncologists and clinicians and the scientists. And after that, the report is created. Once the report is created and ready to deliver, again we do post-test counseling and the report is delivered. So I have shown it as report creation, post-test genetic counseling, report delivery, but the last two steps most of the times happen simultaneously because generally people come for the report and the counseling is done. So this is the simple process which is followed at the level of the patient or the counseling, which means for the person giving the sample, this is a very simple process. But as you can see, after sample collection, next generation sequencing, data analysis, data interpretation, report creation, these 4 steps require rigorous intelligence, intellect, diligence, hard work, databases, analysis, interpretation. It's a huge amount of scientific and technical work which is involved here. I mean, beautiful machines are there which help us in sequencing, but at the same time, we require intellect to interpret that data. And we have got a wonderful team here which does that. So after the report is delivered, kind of genetic test and results are complete. Now, the next question is there, what type of NGS tests are there and what are the samples required? That question is asked by the patients for both types of tests, which is for personalized treatment as well as for germline testing, for example, whole genome sequencing. So here, if you see what I'm showing, a tumor tissue. Here, if you see the first picture, we can see biopsy blocks or FFPE blocks. For personalized medicine, we have somatic panels. We have somatic panels starting from 50 genes to 500 genes, or maybe whole genome, whole exome. All those can be done for somatic panels. The somatic panels are basically done for personalized therapy or targeted therapy. Now here, sometimes what happens, the tissue is not sufficient. And maybe the DNA is of not good quality. So we also have an option for liquid biopsy. Liquid biopsy means blood sample is taken and tumor DNA is extracted from the blood. And then targeted therapy test is done using those DNAs and RNAs. So for somatic panels, we have both types of test, tissue as well as liquid biopsy. So we tell it to the patient, and whatever is suitable for them, that is generally prescribed by their clinicians, or even after understanding the test, they also understand that. Now coming to the next part, which is germline panels. Germline panels there are various types of germline panels, starting from hereditary cancer panels to whole genome sequencing. Hereditary cancer panels can be of say organ-specific, like breast cancer panel, hereditary breast cancer panel, hereditary ovarian cancer panel, hereditary pancreatic cancer panel, hereditary colon cancer panel, hereditary endometrial cancer panel, something like that. And then there can also be hereditary rare disorders panel. Like I said, hereditary cystic fibrosis panel, hereditary hemophilia panel, something like these panels, and then the comprehensive hereditary cancer panel or comprehensive rare disorder panel. The biggest panel is like whole exome, and even the bigger is a whole exome, and the biggest is a whole genome sequencing. So whole genome sequencing, why I'm emphasizing again and again, because whole genome sequencing, if I do, then I come to know, I can be proactive in taking actions for my health. So that's why I'm emphasizing on whole genome, because whole genome gives me information about predisposition towards any rare disorder, hereditary cancers, carrier screening, as well as pharmacogenomics. So we can do these tests, these germline panels, using blood samples, simple blood samples, which are generally taken in EDTA tubes. So these are the tests and samples, these kind of panels and samples are taken, and these are explained to the people or the counseling during the counseling session. The next question which comes to the counselor's mind, why are you asking questions? I mean, why is the genetic counselor asking questions? And what kind of questions they are asking? So it's like we are supposed to collect the information during genetic counseling, because this information helps me in giving better results for the reporter. So what information we collect? We collect personal medical history. If there is already any disease in the patient or the counseling, and then also about family history, family medical history. So if there is any disease which is running in the family, so for that also we take the history. We also take the genetic testing history. If already some genetic test has been done in the family, if there are already genetic test reports available for family members or for the patient or the counseling, we also take that information. Pregnancy history for females, we also take the pregnancy health history. Maybe if there were some miscarriages, or during birth of the child, if there was some problem or not, this kind of history is also taken, because all this information helps us in interpreting the results in a better way. Lifestyle history, environment of living, this is also very important. As I talked about smoking, similarly, if somebody is working in UV exposure, somebody is working in a chemical factory for very long duration, these kind of atmospheres, these kind of lifestyle, or somebody is obese, or somebody is eating a lot of say unhealthy food, so these kind of lifestyle history is also important for interpreting results in a better way. So this information is collected during genetic counseling, and then we also create pedigree chart, which means family chart with different diseases present in the family and lifestyles and all. We create the family chart. We create a genetic counseling summary. We give it to the patient and to the counselee as well. And this is also given in the laboratory so that they can also read it and give better results. Now, the next question which comes to everyone's mind. Okay, fine. I have done the test. I have got the report. What are these results? And what am I to understand from these results? So let me tell you, according to international guidelines, the results reported in genetic test report are of 5 types. One is pathogenic. The second is likely pathogenic. Third is variant of unknown significance. Fourth is likely benign. Fifth is benign. So if you see the definitions here, likely benign and benign variants have no clinical effect. And these are supposed to be normal. These are supposed to be negative results. They are not reported because these are negative results. They don't have any clinical effect according to guidelines. Now, the most important ones are abnormal and positive, which is pathogenic and likely pathogenic. So let me tell you the simple meaning of benign and likely benign. Benign means not harmful. Likely benign also not harmful. Pathogenic means harmful. Likely pathogenic is also harmful, which means abnormal results, and these are positive results. And these are reported in the report. And these can be the reason for the disease. And these mutations or changes will also tell me about the targeted therapy. These results also tell me if I am predisposed to any disease, any hereditary disease. So these are the results which are important and always reported in the report. And after these results, what should be the next action? That should be planned with the help of your clinician or with the help of the healthcare provider. Now, fifth one, variant of unknown significance. This is a bit tricky result. Why? Because we still don't know whether it is harmful or not harmful. We don't know whether it is pathogenic or benign. So far, whatever research has been conducted, whatever information is available, based on that, we cannot say whether this variant is harmful or not. So we call it variant of unknown significance. And we say that at the moment, we don't have to worry about it. So it is like this. We have 5 types of results, and these results we explain to the people in counseling session. Now, the next question comes up. Okay, fine. I have got the results. Now what to do? What next? So with the help of these results, we tell the people, or the people can make informed decisions about targeted therapies, which means if we are giving the reports for personalized medicine or targeted therapy, this helps the clinicians in selecting the appropriate medication for the patients. Its genetic test report is not the only thing for selecting the targeted therapy. There are multiple other clinical factors which are available, which are with the clinician only, the treating clinician who knows the patient best in their own best in comparison to anyone else. So they can make informed decisions about target therapies, medication selection. They can use the medications which may avoid adverse reactions. Surgical decisions are also sometimes based on these kind of tests. Other than that, risk assessment can be done using the germline testing. Then preventive surgeries can be planned. Regular medical checkups and monitoring can be started. It's like regular surveillance. Not just that, extended genetic counseling for the family members and testing if it is required. Suppose if in a patient's germline testing, a pathogenic mutation comes up, then the other members of the family should also be tested, because there is a possibility that their siblings or first degree or second degree relative, they are also carrying that mutations. Lifestyle changes can be made based on these results. I mean, we may go and opt for a healthy lifestyle, say healthy diet, more exercise or appropriate exercise. All those changes can also be made based on these results. Reproductive decision making and family planning can also be done based on these results. Improvement in quality of life, of course, it is possible. Sorry for the spelling here. I have written capital I. I'm sorry about that. So improvement in quality of life. So you can see there are so many things which can be done based on unique genomic profile. Why? Because each and every person is unique according to their genetic makeup. And then we can take decisions, we can take proactive decisions about treatment, as well as proactive actions about our lifestyle and our health based on our genomic profile. So here, these are the things which can be done based on the report. The next question arises, after all this discussion, so once again, the people ask, what are the advantages and what are the disadvantages? So advantages and disadvantages, sometimes they overlap, sometimes they contradict, sometimes they're good. And sometimes, so advantages are early diagnosis and intervention. So it's like if I have done some proactive tests like whole genome sequencing. So I know, like in my case, I know that I'm a CFTR carrier. Now what to do? I got it tested for my son also. My son is also a carrier. So what I have suggested to him, whenever he is going to get married, he should get the girl also tested and take further action accordingly for next to next generation, my next to next generation. So not just that, early diagnosis, any disease can be diagnosed early. So what I say, if I do these kind of tests, either I will avoid the disease because I already know and I am going for regular surveillance, I have changed my lifestyle, I'm taking care of my health, or I can delay the onset of the disease. If something is going to happen to me at the age of say 40, maybe it will happen at the age of 70. So I'm going to delay the onset of the disease. Or I can have the disease, but I will come to know about it at very early stage of the disease. Suppose if there is a cancer, and if I come to know about it at the first stage or 0 stage, I can treat it, I can cure it. So that is another thing which helps me here, early diagnosis and intervention. Personalized medication, as I told you, unique genomic profile, unique disease profile, so unique medication. Informed health decisions, of course, proactive decisions and other health decisions, that will be informed health decisions because now I know my genetic profile, risk assessment and management, and psychological relief from uncertainty. So if I know something, then it is a psychological relief from uncertainty. What I say, a known devil is better than unknown devil. So if I know something, I can take action on that. If I don't know something, I will always live in dark. So psychological relief from uncertainty. Disadvantages. Now coming to the disadvantages, it starts with psychosocial issues. We were saying psychological relief from uncertainty, but at the same time, psychosocial issues. Sometimes people say that, I'll tell you, there are psychosocial issues, but the thinking is changing. The thought process is changing. 12 years ago or 11 years ago, when I had started talking about BRCA testing, people were saying, if I come to know about BRCA mutation, suppose if my daughter has BRCA mutation, who will marry her? Because she is at a higher risk of having certain cancers. But after 10 and 11 years, what I can see that the girls and the boys, especially young people, young generation, no matter whether they are males or females, they are saying that wedding is not important for me. My marriage is not important for me. My health is more important for me. And they are coming up with for the testing for whole genome sequencing. Like I have counseled couple of say very young people, and they got tested also, and they're relieved because some of them did not find anything in their genomes at all. So there are psychosocial issues, but the thought process is changing nowadays. People are worried about the implications for the family members if there is any mutation, but that can be handled. As I said, known devil is better than unknown. Privacy concerns, of course, who is going to know about the results? I'll tell you about that in next slide. Limitations of genetic testing results. So ideally, nothing is ideal. 100% you cannot get 100% from say the genetic testing also. So sometimes there are limitations which are also sometimes of concern, but in most of the cases we get the good results, or we get the appropriate results, I should say. Cost and accessibility is one of the issues. Cost is there because these are expensive tests. Why? Because running the test itself is a costly affair. It's an expensive affair. So cost and accessibility. Accessibility means it's not accessible everywhere. Most of the metro cities have the accessibility. It is still to be, it is still to reach to the, say, the smaller cities and rural areas. Turnaround time of the test results. Turnaround time is very, very important because these, as I said, these tests are expensive tests. So single sample cannot be run. We run the samples in batches, and that's why there is a turnaround time, which is to be reduced as much as possible. So these are the disadvantages. But all said and done, what I have seen in my 10 years of experience, that people are coming up with for the testing, for the genetic testing, to take proactive actions, which means whole genome testing, or the test which can tell them in advance for themselves, for their parents, and for the next generation, if something can be done proactively to have a healthy life. Now, the next thing is, privacy. So who can access the results? As I was saying, people are worried about the privacy of the genetic test results. So access of the genetic test results is given to patient, healthcare providers who is prescribing the test, authorized family members according to patient, laboratories and testing facilities where the test is happening, and research institutions depending on the consent obtained. Standard rules and regulations are followed to ensure the security and privacy of individuals' genetic information. This is very, very important. And genetic counselors, they adhere to ethical guidelines to ensure patients that patients have understood clearly, and that the testing and the implication of testing. And after that, they have provided the informed consent. Again, I am emphasizing on the part that this is an informed consent in a non-directive fashion type of counseling. We do not do directive counseling. This is non-directive counseling. We just provide the information. We help them in making informed decision and giving informed consent. And after that, the testing is done. And if they give the consent, only then the results are shared with appropriate and relevant people. So privacy and confidentiality of data and results is always maintained. Now, we spoke about the do's, but there are certain don'ts also for genetic counselors.
Dr. Jyoti, sorry to interrupt. Could you please conclude in few minutes so that we can have Q&A session as well?
Sure. I just need 3 minutes. Just 3 minutes.
Thank you.
Okay. So you can see that genetic counselors can interpret the results, but they do not guarantee the outcomes. They give emotional support, but they do not do psychological therapy. They are not trained for that. Genetic counselors help in making informed decisions, but they do not take any decision. They do not force anyone. Genetic counselors explain their reports, but they do not take decisions on behalf of anyone. They gather information, but do not make any medical decisions. They complement other healthcare providers by giving them the information as a multidisciplinary team, but they do not replace others' roles. They also maintain the confidentiality and privacy of the patient and do not disclose it to anyone. Here, I just want to give one example of germline testing. So Angelina Jolie is a Hollywood actress. If you see the family history of Angelina Jolie, her mother had ovarian and breast cancer. Her maternal aunt had breast cancer. Her maternal grandmother had ovarian cancer. So Angelina has high chances of having ovarian and breast cancer. Then she was counseled by Dr. Christy Fung, and she got tested for BRCA mutations. And after she got BRCA gene mutation, Dr. Christy again counseled her, and Angelina took preventive actions for that. She went ahead with preventive surgery. She went ahead with double mastectomy, removed both the breasts, and she removed her ovaries as well as fallopian tubes. From her side, she has made herself safe from ovarian and breast cancer. So these kind of preventive actions can be taken. But suppose if that is not possible, at least we can go for regular surveillance. We can go for regular medical checkups and follow-ups. Now, last but not least, what I want to say, genetic counseling in a nutshell is from monologues to dialogues. What I mean by that so far, what doctor is suggesting, what people are suggesting, whatever healthcare provider is suggesting, patient is just following that and going ahead with the treatment. But for genetic testing, what I say that we converse, we talk to each other. Genetic counseling in the era of whole genome sequence and next generation sequencing is about empowering the common persons with comprehensive scientific and technical insights about their genetic makeup, help them making informed decisions, and navigating the intricacies of their health through simplified conversations in a non-directive manner. Here, I end my talk. And yes, Aarti, please let me know if there are any questions.
Thank you, Dr. Jyoti, for Thank you, Dr. Jyoti, for this insightful presentation. We will now start with the Q&A session.
Sure.
The first question we have with us is why whole exome sequence is not preferred over whole genome sequencing regarding testing and diagnostic perspective.
Testing and diagnostic perspective. Aarti,
yeah, which is the preferred mode of sequencing, whether one should go for WES or WGS for testing and diagnostics?
So diagnostics, let me just close the presentation.
Sure.
Yeah, but that's okay. So diagnostic, it depends on what clinician is prescribing, what kind of test clinician is prescribing. For that, whatever panel, whatever kind of test is required, we will do that. It not necessarily whole exome or whole genome, but it will be kind of whatever clinical indication is there, and based on that, whatever clinician's requirement is there, and whatever is required, that test will be performed. It can be 2-gene panel, it can be whole exome, it can be whole genome, depending on that. For diagnostic, we don't do that. But for comprehensive genomic profiling, if you want to know, if you want to take, you do the predictive testing kind of thing, or you can say that you want to have the preemptive testing, then we suggest whole genome sequencing, because there you can also do the pharmacogenomics, and we come to know about the whole genome rather than only the exonic region of the gene.
Okay, understood. And when whole genomes would become common and as evidence would emerge, how would a counselor handle reanalysis of data as new evidence emerges?
If I am understanding it correct, are we talking about, is the question about if it becomes very common, is it going to be huge data or something like that? Or what is the question? I'm trying to understand that.
Yeah, so when the whole genome sequence would become common, we would have a lot more information compared to whole exome. So how a counselor is going to handle this information?
Yes, of course. So yeah, it's a very good question. Why? Because right now itself, when I do the counseling for post-test counseling for whole genome, in pharmacogenomics, there is a lot of information about the drugs and the responses of an individual towards that drugs. So that is there. Look, I'll tell you, a carrier screening, predisposition, these tests, we are not going to get huge data for a particular individual. Why? Because I say that God is a great programmer, and he has done only, say, one or two mistakes or one or two bugs in their programming code for a particular person. So that is not going to be a huge problem for handling the data for a genetic counselor while interpreting or explaining the reports. But yes, of course, pharmacogenomics, that we have to understand and we have to explain very well. And that, let me tell you my own experience. Whenever I am going to explain this report for pharmacogenomics or whole genome, first I prepare my notes, I get all the details, and then I go ahead with the counseling. Yes, we have to do a lot of work. That is true.
Nice. And now, can you explain the significance of variant classification in the context of genetic testing?
Significance of variant classification.
Like you mentioned, 5 categories we have.
Yes, yes, yes.
What is the significance of these classification when it comes to genetic counseling?
Sure. So yes, so it's very common thing. Suppose if I am getting one test, even if it is simple HbA1c, I would like to know how it is going to affect HbA1c. If the value is below HbA1c level, then I'm hypoglycemic. If the value is above HbA1c reference range, then I'm a diabetic patient. If it is in the normal range, then I'm fine. So that, in the same manner, if you take this analogy, you can say that if I do not have any results reported in my report, which means negative, then I am fine. I do not have any, say, okay, fine. Let me take it in 2 ways. Yeah, it's not so simple. So in somatic mutations, it is very, very important to know what kind of mutations is present, because that gives me the root cause of the disease. That is first thing, especially in case of cancers. So for personalized medicine, if I have a mutation for which the drug is available, it is going to help me in personalized treatment. So that is why this knowing about the variant is very, very important. So if I have a pathogenic mutation, this gives me the root cause of the disease also, and at the same time, this gives me the personalized medicine. Now coming to germline mutations, if I don't have any mutation, if it is negative, then I am free of, it's like uncertainty is gone, and I do not have any mutation which is going to cause hereditary disease. But if it is a positive mutation, which means a pathogenic mutation, then of course it has got a significance. Why? Because maybe I would like my family members also to be counseled and get tested. And for myself, if I'm healthy, I would like to know what kind of surveillance protocols are there, what kind of screening protocols are there, which are going to help me in future to avoid or delay the onset of the disease. Now, here there is one very good example of BRCA1 and BRCA2 mutation where you get contradictory kind of opinion. So BRCA1 mutation and BRCA2 mutations, if they are found in an ovarian cancer patient or breast cancer patient, and so these mutations are helpful in deciding a medication which is known as PARP inhibitor. But at the same time, if these mutations are present, if these germline mutations are present, they are also indicative of predisposition towards hereditary cancers. So yes, these are to be handled very carefully now during the genetic counseling session, because when we say BRCA1 and BRCA2 mutations are present, we tell them it's a good thing, you can get olaparib or you can get PARP inhibitors. But at the same time, we say that yes, you are predisposed or you have this germline mutation, so other family members should also be counseled and tested. So it's kind of tricky situation. We should handle it carefully. We do handle it carefully. Another thing, variant of unknown significance, for which we still don't have any solution. So we are supposed to handle it very, very carefully. It's like it's neither harmful nor benign. So we say that right now you don't worry. Yes, of course, in future, if the information comes that this particular variant has been defined as benign or has been defined as pathogenic, this information should be provided to the person who has got the result as variant of unknown. I hope it has answered. Yeah. Okay.
Yes. And this is one of the very basic questions. Who are the people who should undergo genetic testing?
Very good. So genetic testing, if there is, so let's talk about the germline mutations first, or hereditary genetic testing first. If there is a family history of genetic disease, in case of cancers, if there is a family history of hereditary cancers, or if there is a personal history of hereditary disease or hereditary cancers. In case of cancers, if there is a young age cancer, a cancer below, you can say 45 years of age or 50 years of age, basically 45 years of age, the young age cancer. This age also varies from geography to geography, but yes, young age cancer. And if there is a male breast cancer also, in case of breast cancers, male breast cancer is very rare, but if there is a male breast cancer, then also hereditary genetic testing should be done. In case of breast cancers, triple negative breast cancer, if it is there, then also we should go ahead with hereditary cancer testing. If there is a colon cancer, history of colon cancer in the family, and endometrial cancer in the family, then also we should go ahead with the hereditary cancer testing. Now, if there is history of rare disorders, or if there is history of, say, in a person of rare disorder, then also we should go ahead with the hereditary panel testing. So there are various aspects, there are various reasons why a person should go ahead with genetic testing. The thumb rules are like this, that if there is a family history of any rare disorder, any genetic disorder, and if there is personal history of any genetic disorder, if there is young age genetic disorder, then we should go ahead with genetic counseling and genetic testing. For yeah, just one more thing. For therapy, especially in the case of cancers, if I think most of the people are going ahead with the genetic testing, because cancer is a genetic disorder. When I say genetic disorder, I don't mean hereditary, but there is a flaw in the genes, and that's why we have cancer. If I smoke, I have acquired cancer. Breast cancer can be acquired as well as hereditary. So whenever there is a cancer, we need to have the unique genomic profile, because each cancer is unique because of unique genomic profile, and hence the medication. Yes, Aarti.
Thank you, Dr. Jyoti, for this insightful presentation and your
Aarti,
precious...
Aarti.
Yes,
I have one question to Dr. Jyoti.
Please, sir.
Dr. Jyoti, you briefly mentioned that these these tests are very costly, but I would like to know that whether if somebody has a medical insurance, whether these costs are reimbursable partly or fully or to some extent.
So, sir, so far, insurance does not cover the genetic testing. So far, but if it is like, say, if the what in my experience, I have seen a couple of cases where it has been say prescribed by the doctor for the treatment, then it is reimbursed depending on the on case by case basis. But in general, it is not say covered by insurance.
Yeah, obviously, it will be only if it is prescribed, somebody will do it, no?
Yes, sir.
On its own, he will not do it.
Yes, sir. But, sir, for hereditary, I still don't know whether they are going to cover it or not. I'm not sure of that. So I have not seen that.
And any government grants are available for this?
For hereditary for testing of genetic testing, sir?
Testing.
Yes, sir. Research projects and all are there. From where we can get the grants. For
Okay.
clinical settings, I don't know. I mean, it's not in my knowledge.
No, I understand.
Yeah.
I understand. But this is like a general query. It affects
Yes.
the large mass, the end
Yes.
user.
Yes.
Correct.
Yes. Yeah. Yeah.
And very good. Otherwise, it was very informative session you gave.
Thank you, sir.
And because some of our friends who are non-medical also, like one Madan Vaishnav is there. I know him. He had also asked, is cancer disease genetic? And means if parents had cancer, then chance to child is also bright. Is it bright due to genetics? So I think you have answered that.
Yes, sir. Yes, sir. I mean, if required, I can do the counseling also for that family if necessary, if required.
So once again, thank you all for attending and making this success, this webinar series.
Sir, there is one more question, I think. Okay. This is here.
Yes, Mithul Abhinav has asked, ma'am, I am a BTech student pursuing genetic engineering. If I want to become a genetic counselor, what necessary steps should I take to achieve this?
Please contact me, Smrital. I'll tell you. Please contact me. Okay. Fine.
Sure.
Yeah, okay.
With that, we conclude today's
Sure.
session. And thank you, Dr. Jyoti, again for sharing your invaluable knowledge. I would also like to extend my sincere gratitude to all the attendees for their active participation. And we will soon be notifying you about our next webinar, and we hope to see you there. Thank you, everyone.
Thank you, Aarti. Thank you, Rajesh sir. Thank you, everyone.
Thank you, Aarti. Thank you, Jyoti.
Good night.
Thank you, all
Good night.
participants.
Thank
Good
you
night.
all.
Yeah.
Good.